Do you move the slide? Do we say next slide, please, or did you give us a slide mover?
You can probably just push this button.
Okay, so it is just a minute past noon. I guess we'll get started. Welcome, everyone. Hello, Dr. Champney. Welcome. And are you putting up our slides for us?
Oh, you ready for that?
Yeah. Okay, and I'm Gayatri Jaishankar, and we have Matthew Tolliver here. We're presenting jointly around engaging with families around healthy behaviors and early literacy. So welcome to our wrap-up echo session for this series. We do not have any disclosures or financial interests or agreements, and do not anticipate discussing unapproved or investigated uses of any products. So I'd like to start by outlining our learning objectives. We, through these prior echo sessions, had really actually discussed lots of different ways and tools to engage with families around healthy behavior, and realize that at a systems level, we do many things. And our goal with this session was really to, on a one-on-one level, discuss how we could engage with these families. So number one, I'd like to discuss the importance of effective agenda setting in engaging with families. Number two, and here's where Dr. Tolliver is going to really take over for us, apply some introductory motivational interviewing concepts to family engagement. And then last but not the least, take us through a little one-on-one of how I would engage with a family in clinic to maybe then help us outline what elements would make up that secret sauce. So you're going to learn about Dr. J's secret sauce by the end of the session. I think those of us in healthcare identify fairly well with what we have up on the screen, what's called the difficult patient or family. And really, I think it does become a vicious cycle. Dr. Tolliver will help us understand the steps of this later in the presentation. But the patient digs in, defends their position, really is oppositional, say, in the eyes of the provider. The provider uses a very direct style, argues for change and says, I know this is how we should do it. I believe I'm saying this because this is right for you. The ambivalent patient then argues against that change and says, no, I'm not really sure. I mean, I understand what you're saying, doc, but I'm not really sure I'm ready to do that. And that makes us think about that patient or that situation as difficult, if you will. And in wanting to help them more, we end up giving them more advice, which really is then counterproductive to what we might need to do. Many times I have residents or students come up to say, Dr. J, if only they had the right information, maybe I just didn't present it well enough. If only they understood what was at stake, I can give them the solution. I can make them do this. And really what we realize is that as healthcare providers, we have a very strong writing reflex. And so we really want to help. We, by virtue of our profession, by going through medical school and residency and graduate school, have this drive to be successful, to overcome obstacles, and in turn, learn a lot of information that we feel we need to impart to these patients and families and tell them that this is the right way to do it. We feel really obliged to say, oh my gosh, you're going down the wrong path. Let me tell you how we can solve this for you. And oftentimes that's maybe a way to approach it, but oftentimes is not the right way to help engage with families. So in thinking about how we would start with engagement, what we do want to do is to follow the steps of effective agenda setting. Step one, and really this needs to be very, very brief, 30 to 60 seconds. This is something that we learn in medical school, we refine as we go through and practice, what's often referred to as the art of medicine. Simple things. Welcome the patient by name. Introduce yourself. Identify your specific role. If you work as a team, tell them what each member of the team might do. Make sure that they're ready and comfortable to get into the interview. Ensure privacy for them. And remove any barriers to communication. Sit down, connect with the child, talk to them one-on-one. And these are simple things, but oftentimes we overlook those in our hurry to get to the meat of the matter, and really are very, very important in forming that doctor-patient relationship. The next step, which again should be very, very brief to be effective, is to elicit their chief concern and set the agenda based on that. Indicate that the time that you have available. Tell them you're here for a well check with me. In the next 15 minutes, I'd like to know a little bit more about you and forecast all the things that you would like to happen at that visit. Obtain a list of issues, request what they might expect of you, and narrow them down if there are too many. Summarize what you do hear from them and finalize the agenda. And oftentimes we have these patients, they have a laundry list of things to tell you. Negotiate with them if you find there are too many items on that list. If they are saying, I think that they have frequent headaches and I'm worried about their weight and they're here for a checkup and we need our immunizations and the list goes on. Try to pick out of that list and say, I do understand you have many concerns and I would like to get to the bottom of all of those concerns. But to me, the thing that seems to be important today is for us to talk about this together. Would that be okay? So summarize what you might want them, what they might want and what you might want to talk about. Your third step would begin with non-focusing skills that allow for patient expression. And again, this is a very brave step, but open-ended requests are important. Look for nonverbal cues. Tell me about your headache. Tell me a little bit more, open-ended style of interviewing. Look at them, look at their physical characteristics, look at their environment, look at their recruitments. Do attentive listening. Silences are great. Sometimes you get a whole bunch out of really being silent and listening to what they're saying. Neutral utterances are often very helpful. Just a little bit of a look or a thought is very, very useful to get them on the same page as you. In your fourth step, you really want to use focusing skills to elicit their symptom story, and not just their symptom story, but also understand their personal context for that symptom story and their emotional context. Respond to feelings with emotion and empathy. In the fifth step, in which you're then going to transition into the middle of the interview, so this is just really your effective few minutes worth of agenda setting, you briefly summarize, check for accuracy. So repeat back to them and say, is this right? And then say, I'd like to switch gears now and ask you some more questions to better understand what may be going on. So this is pretty much how I would start the interview with effective agenda setting.
And then I don't know, Brian, maybe you can let us see who else is here. I think maybe one more person joined us. It's weird not being able to see people.
Mm-hmm.
Did anybody else join us? I heard of. Okay. Maybe not. Okay. that's fine to keep it up there as long as it's not blocking their view, because then we can kind of.
Yeah, that's right. Thank you.
Okay. So I wanted to talk a little bit about something I realized when I was in 6th grade about engaging families. A couple of things that I didn't realize were evidence-based at the time, but it turned out to be. So when I was in 6th grade, my brother and I kind of embarked on this campaign to try to get my mom to quit smoking. And we did this by kind of any means necessary. And so we'd sneak into her purse, we'd cut up her cigarettes, we would lecture her about all the bad effects of smoking. We'd try to write all these lists about if she quit smoking, all the great things that would happen to her. And we even tried to make her feel guilty by when she came home from work, we'd be like out on the back deck, like acting like we were smoking cigarettes. So of course, none of these things really worked. And what we really know now is that those kind of fall into some categories that we know from empirical evidence are less helpful when we're trying to engage with families. And so I wanted to just review 3 of those, and then hopefully have it be a conversation about where do you see these seeping in to clinical practice, maybe unintentionally. And one of those I think that's difficult for engagement, we'll talk about kind of the 3 things that I think aren't helpful, and then maybe some 3 tools that we can use to engage families. One is just scaring people or scaring patients, and you all might have seen this Beyond Scared Straight TV show before, where you take some troubled teenagers and who are at risk, and you get them to be in jail for a day and kind of see how that goes, and with the hopes that that will change their whole trajectory and they'll never kind of be involved in bad things again. And what we actually know from evidence around the effects of this is that the teenagers who went through this program were actually more likely to offend than teenagers who didn't go through the program. So just scaring people alone isn't, we know, very effective. And I think sometimes, for each of these 3 things we'll talk about, providers, we don't do this intentionally with malicious intent, right? We're not trying to go out and make somebody feel bad or make somebody or try to use this technique just to scare them. We're trying to, sometimes out of desperation, get folks to change or try to engage with them. And so Dr. J was going to give one example maybe about how this might apply to clinical practice.
So for me, in thinking about what are the times that I've scared people, I realized that, as Matthew said, before I knew all of this evidence-based stuff and early on in my practice, and even now sometimes because I'm passionate about it, when the topic of vaccines come up and a family that doesn't want to vaccinate or completely refuses to vaccinate makes me really, really passionate about it. And so oftentimes, especially in the early days, I would really argue with the family and talk about this, you're doing harm to your baby. Your baby is going to come in here dead. And we're, all these serious illnesses. And the next time your baby has a fever, we're going to have to, take 100 tests for them. We'd have to admit them for meningitis. We'd have to do all these things to your child. In thinking back over the years, that really oftentimes hasn't helped families. That alone has not been the only thing that's helped families to then come to the conclusion that they need to vaccinate their child. So for me, that's, kind of the realization. I just can't scare them into vaccinating their child. I was also going to ask if Heather or Sarah on the call had any other thoughts about how that might apply. Like in your practice, have you had any examples of where you've tried to scare someone and you find that that doesn't work?
I don't specifically try to scare them. I try to test the possible risks and benefits and try to find out where they're coming from. And recently I had somebody say, oh, we like the vaccines, we just don't like the STD vaccines. And
Mm-hmm.
I do say sometimes, until you've held the hand of a child that's dying from whooping cough or something like that, it's hard to understand why we have to do this or why it's better to do this. And I tell stories. And I guess maybe that's an attempt to scare them, but I'm not in my mind trying to scare them. I'm trying to just help them see that other people have suffered from these things that were in it.
Mm-hmm.
But I try to acknowledge their fears and then say, well, if you don't want to vaccinate, that's up to you. It's not my job to make you do it. My job to recommend, and would you please sign the vaccine refusal form? And they usually do. I've had one that said, oh, I want to read it and I'll bring it back. And they never brought it back. But I didn't fire them either. So maybe they'll change their mind later as I continue, hopefully, to be supportive and willing to vaccinate and give a strong endorsement and tell them I vaccinate my kids on time according to the CDC recommended schedule. And I think that is more comforting to people than anything, to have the provider say, you know, I vaccinate and I believe in this. Because it comes down to a belief, it seems to be.
Mm-hmm.
They either believe it or they don't. And if they don't believe in it, and there's no amount of arguing and scientific evidence, it seems to change their mind. So
Right.
I have to choose just to not get emotionally involved in it, which is hard.
Mm-hmm. Yes, and I don't think I was intentionally scaring them at first, but I realized in looking at some of these evidence-based things that we found that was probably part of the reason they said no, was because I was maybe unintentionally scaring them.
Another one I think is just when people end up feeling guilty because of an interaction with the provider, and again, none of these things are things that we do intentionally, but sometimes even unintentionally, the way that we phrase things or just the presentation can end up making folks feel guilty. I think a big one is around like weight management or things like that. But another kind of study around this one was Mothers Against Drunk Driving. They formulated this victim impact panel where folks who had DUIs would go in front of this panel and they would hear stories about people who had lost loved ones to drunk drivers. And the attendees, the folks who had the DUI, reported that it really had an impact on them, that they were really going to remember that message, that they felt really bad about themselves and felt guilty about it, and that they were never going to drive drunk again. But some follow-up studies around this found that for first-time DUI offenders, there made no impact in their likelihood to get another DUI. And actually, the folks who had 2 or more DUIs who attended the panel were more likely to get another DUI than folks who had not even been through the victim impact panel at all. And so, in general, I think this is a great example of that organization was not trying to make people just feel bad about themselves. They were trying to kind of infuse this message of, wow, your actions have an impact on other people, and in kind of this strong way, but kind of the data didn't bear out a change in their behavior afterwards. And so I don't know if you have an example that you want to talk about for that one, Dr. J, or.
And I think what you said in the beginning about sort of the weight management piece, that's where I find a lot of times I end up making people feel guilty in my clinic. And like you said, intentionally or unintentionally, sometimes, you know, you do feel like telling them, oh my gosh, don't have so many sweets. You know, why are you drinking so many sodas? Don't, do that. And that feeling of guilt that does get infused in them, I've not really been found to be very helpful in the long run in actually having them make the change. And for me, that sort of is an example of the guilt piece.
And then I think the last one that comes up most for me personally is kind of what we call the data dump, right? When we just are in advice giving mode and we have lots of facts and figures and statistics and good legitimate evidence for why we're recommending what we're recommending. But instead of it being like a collaborative process or a back and forth, it's more of, okay, I'm going to kind of dump all of the reasons for change or all the reasons that I would recommend this on you and then move on. And it's kind of like the just do this or just say no attitude that I grew up in the DARE era when I was in elementary school. And, the motto is just say no, right? And we know that like a big meta-analysis of that DARE program basically showed it had no beneficial effects in changing kids' likelihood to use drugs or not. And so I think I'm probably most guilty of this one sometimes when I go in and work with a family, and because I know all of the literature about a certain topic, and so I get passionate about it and I want to tell them about it. But sometimes if I don't check their level of engagement at the beginning, I've kind of maybe wasted the 5 minutes of explaining things if at the end of it they are like, yeah, I don't really care about this anyway.
And for me, a big example of this was when we've done the ACEs screeners here recently. If I just walked in and said, hey, your ACEs were really high, here's what we've set up with the community, here's what you should do, here's all the things we can do for you while you're in clinic, I find there's almost zero buy-in. Whereas if you take a few seconds of your time to explain what is available, what ACEs are, what has shown to be good, just kind of, and then get their buy-in in terms of being able to do that, then the response has been much more positive. And I've had like multiple occasions where if you don't engage them in that conversation, then that's not something that they're going to do. Dr. Skitzina has something to say.
Dr. Skitzina. I was just going to say, going along with what Dr. Jaishankar was talking about with our ACEs screener, one of the things I've started to do if a parent or caregiver has a high score is say, you have a high score, this is something that we're screening for in our clinics. We want to help families with any resources. How have these experiences that you had in childhood affected you? How are they affecting you now? Are they affecting you? And then, I've had parents who say, well, now I've kind of worked through that. They're really not affecting me, versus parents who say, well, it is affecting me. Mainly with my spouse, we argue a lot. I get really angry. I'd like help with that. And so just sort of starting off with a question to them about what they think has helped me direct the conversation. Instead of, like you said, going in and saying, here's all the things we can do and offer you.
And I think I didn't expand on with the agenda setting to assess the emotional context, and that's where that comes in, is really to understand for any problem what their emotions are tied to that problem. So how has this affected you? How are the headaches hurting you? What do you feel about your weight? To really assess the emotional context of what that presenting problem may be is usually helpful in getting buy-in from them in terms of that.
Yeah, and I think I heard the quote, it was saying that education is not as powerful as engagement. So just kind of that advice giving approach sometimes I think shuts other people down. What do you all think? I mean, agree, disagree with these three? Are there others that you would add to this list, or just from your own clinical experience that you feel like are things that you've just noticed over your clinical practice over the years that tend to shut down engagement?
So I tend to, what I've started doing the last couple of years is stating something that's obvious to me, something that I've picked up off of the first couple of minutes of interaction with the patient. So for example, I had a new oncology patient that came to the emergency room the other day, which should not happen, number one. And this mom's completely overwhelmed, and she's trying to spout off all of this information in response to my questions in a pretty urgent fashion. And she was all over the place, and she hadn't even, if someone had told her she hadn't heard it, that she should write down this event that had occurred in the process leading up to this girl's really tragic diagnosis. And I could tell she was getting stressed, and her voice was, and I just sort of stopped the conversation and said, you're doing a really great job. This is not your fault. And we spent a few minutes talking about the fact that she didn't cause her child to have this terrible diagnosis, and she hadn't caused some of the side effects that were there, and I reassured her that she was doing a great job of caring for the kid. And we just sort of paused in the middle of that really stressful information sharing and engaged as two moms who had kids that needed special attention. And it reset the whole thing. The whole interaction was reset after that. And the mom was grateful and tearful. But once we got over that, we were able to have a really successful encounter. And I think that when you see it sort of spinning, just kind of stopping the progress and changing and connecting with that patient or that parent on a personal level is huge and very powerful. And it gives you, especially in that quick, I don't develop long-term relationships with these patients. Well, I do with some of them. That should not happen. But, these things where I have to very quickly get someone to trust me and do what I want them to do, or at least agree to let me do what I want to do. That immediate something that we can share that makes us both humans, both parents, both working towards a common goal of solving this problem. And then we tend to really have pretty productive conversations in a pretty short setting. So that's kind of been what I've tried to do more so in the last few years. And I find it quite successful.
It sounds like you were able to be attentive enough to really just pick up on, the overt things that were said, but also like her body language and tone of voice, and not just kind of, go through your check boxes, but really kind of go from almost, it sounds like, from just the expert role of I'm the physician, you're the patient, to we're both moms, and kind of take that human to human interaction approach.
Yes.
I think like when I first started practicing now 9 years ago, I felt like I had to show my knowledge to get a patient to trust me, and that I needed to show that I was the boss and the boss of the knowledge and that sort of thing. And I realize now that's not the most effective way to have a productive relationship. I don't have to what the outcome will prove whether or not I know what the heck I'm doing. But, at least we can have a positive experience together if I don't walk in like a know-it-all, and I walk in like another human who just happens to have a set of skills in this moment that puts me at the head of the table, but not necessarily the sole driver of the ship. And I think making that connection with the patient, that you're in it together and you're going to help them for the duration of your relationship, is huge, because then you're not the know-it-all,
Right. And I think that's exactly the data dump piece, Heather. So I would agree with you, because if you approach it as I know it, here's what I know, here's what I'm going to tell you about it, then that really defines your position in a very different way from that, like you said, one-on-one human connection. And I find I always try to get some connection to the family. So, if they offer something, like if I ask about school and I say, okay, so what do you do in school? And if somebody says band, then I try to find some connection to that. Or if they say something else, like, finding that human element for connection, it seems like always is helpful to make the ongoing relationship better.
I think it's awesome that you're able to do it in the ER too, right? Like in that super brief setting. That's awesome. Anybody else? Yes.
I find that if I can find something to praise them for, even if it's a small thing, especially with obesity, if I ask the kid, what have you been doing to try to be more healthy? Even if it's running around outside more or drinking more water, I really build on that and try to say, great job, I'm really proud of you. Now, what else do you think you could do? Because they know, I've already told them, they know what to do. And then it's just building that confidence, and then them believing that I'm proud of them and that I'm in it to help support them and not just fuss at them. Because so many times they come in and think I'm just going to fuss at them, and they're worried about that. And so I try not to. I try to be more supportive and just praise them for their small steps. And I find that's pretty effective.
Yeah, affirmations are powerful things. We all like
great behavioral modification there.
So how many, for you, I think Dr. Champney is, but how many are familiar or have used motivational interviewing in your practice before?
I use it all the time. I've never done specific training in it. I've just read a fair amount, and at conferences, if it was available as a session or a lecture did that. And part of it is that's just the way I interact with people somewhat anyway. And I think it's amazing because then they really do take ownership of, at minimum, the conversation. And, you know, at best, they will actually modify their behavior. And I do think it works. It works with my own kids when I'm trying to not murder them and get them to be reasonable human beings. It really does work. I practice lots of things on them. So I think it's an amazing tool to cultivate, that we should all, you know, just be better listeners. I think that's a lot of what motivational interviewing is, and learning how to pick up on some of those subtle cues and asking them a question in their language. And it doesn't take very long, I think, to figure out what will resonate with a person. And you won't be right 100% of the time, but most of the time you will.
Mm-hmm.
And actually having them frame what the problem is. You know, a lot of times by the time you finish with the interview, not only have they framed the problem, but they've also framed the solution for it. You really don't even have to tell them. They kind of have the answers. And I think that's really the amazing thing when you do practice it, to see how that happens.
Yeah. I didn't know, Sarah, for you, would it be okay if I asked you a few questions about motivational interviewing in your practice?
Sure.
So a scale of 0 to 10. So if 0 is not important at all and 10 is like the most important thing in your practice, period, kind of what number would you give yourself in terms of how important using some of these MI principles or techniques or approach would be for you? If you had to give a number 1 to 0.
I would give them a 9 or a 10. I think they're very important. I have a time limitation to how much time I can really sit and talk and motivate them with this type of interaction. Yeah,
that's pretty high. I mean, given all of your other commitments and everything, a 9 or 10 is pretty high. So, why so high for you?
Because I think it's way more helpful to get the patient engaged and actually make a change in their life. If they're the ones making that decision for themselves and you're helping to lead them to that decision, they're way more likely to actually make a change based on that, versus if I just come and do the data dump.
So you're saying on one level it's just more effective doing that approach?
I think it is, when I can spend extra time, but that's the thing, it comes into a time crunch.
So maybe
do I do it all the time? No. Do I feel it's super important? Yes.
So maybe one of the reasons it's not a 10 all the time is just the time commitment piece of it. Tell me more about the time commitment piece.
Well, to really sit and have a conversation with the child, I feel like you have to sit and really listen, right? So you can't just pop in and out of the room and do briefings. And I try to talk them throughout, but to sit and be patient and wait for their response and really make them feel like you're truly listening with everything, not trying to type at the same time or whatever, which I wind up doing quite a bit of the time, is typing and listening at the same time while I'm looking at them. But it kind of limits their engagement with that conversation when they feel like you're not really giving them 100% of your attention. And when you are, then they're much more willing to get into those issues that really bother them.
Yeah. So, I mean, you're finding it's effective, it helps with patient engagement, but to really do it on a consistent level, like all day, every day, you'd have to figure out a way to make it fit within the time constraints and just the practical limitations that you already have.
Yes.
Okay. Awesome. Well, we will keep that in mind as we go. So I like this example. The creators of MI talk about MI being more like a dance than a wrestling match. And so if you are having an interaction with a patient and it's starting to feel more like a wrestling match, that's kind of a little bit more of just a prompt for yourself that, okay, maybe we need to switch gears here, or like Dr. Champney was saying, maybe we just need to stop for a second and check in about what's going on here, where's the mismatch, and because the more we argue for change, sometimes that brings out an automatic response to be defensive or argue against a change. And the more people hear themselves talk about the reasons they can't change, the more ingrained that position becomes for themselves. So if you find yourself like debating back and forth with somebody for and against vaccines, you may unintentionally be strengthening their original resistance in the first place. Anything else you wanted to say about that for this slide?
I think that, and vaccines are the beautiful example for that, because it seems like a lot of times, the more you're in that room, the more you have that conversation saying, this is why we need to do it. Here's the reasons, you want your child to be healthy. The more that it seems like the other person takes the opposite stance, just because they feel like then they have to have an argument, and they become ingrained in that position more and more. And unless we understand their reasons not to vaccinate, maybe they have autism concerns, maybe it's because the internet said so, whatever those reasons, unless we take the time to understand that, you're just going to have the wrestling match and not the dance.
So does this look familiar to you guys, or is this new? Just the stages of change, pre-contemplation, contemplation, is that pretty familiar? So I won't go into the details of that then, but we all go through these different stages anytime we're making a change. And the one point I wanted to make about this is that if you can figure out what stage of change somebody's in, or like what engagement level they're in, then you can match your intervention to that level and hopefully save time in the long run. Because if you have somebody in the pre-contemplation stage where they have no intention of changing their behavior, then okay, I'm probably not going to spend 15 minutes trying to come up with some big action plan or give all of this information about the reasons for the change, because they're so resistant to it at that point. Maybe the intervention at that point is, hey, is it okay if you take this handout and think about it, and would it be okay with you if we talked about this again at the next visit, right? And so if somebody's at more of the preparation or action stages, then they're more apt to be willing to work with you around engaging around developing a behavior change plan. So I think one way to save time, or to kind of know when to really go in depth or not, would be to match the stage of change that they're in to your intervention, or to the amount of work you're going to be doing with them.
And for that, as far as with the pre-contemplation, I think every year I face it with many patients on the flu vaccine. There are some who are completely, they have no intention of changing that behavior, in which case I really don't spend a lot of time, wasting my time, my breath over why I think that that's really important. A lot of times though, little drops make an ocean. So sometimes, the resident will come back out and tell me, Dr. J, they've always been against the flu vaccine. They're just not going to do it. I will spend a few minutes trying to understand what the pieces of the flu vaccine makes them uncomfortable, or what it is that makes them not want to do it. And we'll give them a word or two about why I think that that's not necessarily the case. And I find that for some families, that pre-contemplation stage, season through season, has actually then led them to vaccinate 2 or 3 seasons down the road. And so I always try, but I base the amount of time I try based on where I feel they are.
So then the question though becomes how do you know what stage of change somebody's in, especially if you're doing a really brief visit? So, and people here too are free to chime in, if you're meeting with somebody or with a parent or with a kid, how do you quickly figure out which stage of change that they're in so that you can match your style or your intervention to that?
I think one of the things that comes up for families that we work with sometimes is that no matter what you're suggesting, they start the conversation off with nothing works. And that's a pretty good indicator for me that they're not ready to make a change.
Sure. What about for you, Dr. Jaishankar? How do you kind of know how engaged people are, how ready they are to change from the beginning? Or do you?
I mean, I think you don't necessarily know from the beginning, but I agree with you with the flu vaccine resistance. That's kind of the way I approach it now. It doesn't take a lot of time, but I'll just start out by asking, well, would you mind sharing with me some of your concerns or reasons why you don't want the flu vaccine? with some patients, I'll get I don't want to talk about it, and we're not doing it. And that to me sort of tells me that they're not contemplating, or they're before that stage, they're pre-contemplating. Whereas not uncommonly, I will have patients mention specific concerns, and then as we talk about that, sometimes they will choose to vaccinate on that visit, or like you said, at a future visit. And so I think just asking some questions and asking them to share, tell me more about it, you can get an idea if it's something they've been thinking about or not.
Sure.
Or if I'm really getting that resistance, then I just say, well, just so you know, I'm always available to discuss, any questions or concerns you have about vaccines in the future.
So we talked about 3 reasons that, the things that don't help with engagement. And so I think these 3 tools are things that promote it, and they're things that you all have already kind of said during the course of our discussion. I want to go a little bit out of order and talk about the scaling questions first, because I think I was with Sarah, we were kind of doing that together, right? Like kind of asking these scaling questions, 0 to 10, how important is it for you to do this particular thing? And I think that one question in itself can help guide you in terms of how engaged is the family around making a change, or how ready are you to make this change? And if you have a much lower number, then you're probably going to kind of be in that pre-contemplation stage. So I think you can kind of map these stages of change onto what number they pick along that scaling question, if that makes sense. Where if they're like you were like a 9 or a 10, so you were like probably in the action stage of you're already doing this in your practice. Somebody who is very resistant to it is not even going to be practicing it or trying to do it. And so you might map your intervention a little bit differently. But these 3 scaling questions about like how important is this for you, how confident are you that you can do it, and how ready are you to change, just those 3 questions in themselves don't take up a whole lot of time and can really get you a lot of good information. And they're more open-ended questions instead of having to ask a lot of multiple closed-ended ones. And what I like to do is kind of like I was demonstrating, say like, well, why not a lower number? And when you ask that, it really pulls for the reasons for change, or the reasons that they kind of pro-engagement reasons. And the more that folks are able to talk to themselves through those reasons for change, the more likely they are to be able to go in that direction. And then you can ask maybe why not a higher number to try to get at just practical barriers, right? For Sarah, it was time, and if I'm going to do an intervention to try to help her be more engaged with MI in her practice, I'm going to need to know those barriers and address those in some kind of a plan for it to actually be effective. So, it's probably would feel a little bit different if I was like, Sarah, if MI is evidence-based, you really just should use it all the time in your clinical practice, regardless of all the barriers. You're not going to have as much engagement probably. And so I think, and if you're worried about time, maybe just using 1 or 2 of these scaling questions and just a why so high, why not, why so low kind of follow-ups might help give you a lot of good information.
And the why not a higher number, I've learned this from Dr. Tolliver, really helps you get to the barriers. I mean, almost immediately you understand and you hear why they feel they're not able to do it, and really helps pick up those barriers for you.
Okay. So the other ones that I think you all are probably familiar with and that you've already mentioned in different ways are just these ORS skills. And these are things that we teach the 1st and 2nd year medical students even at Quillen about, basics of clinical interviewing. They're things that I think if you've practiced for a while, you've just found out work as well and help with engagement. But I think it's easy sometimes to forget, and like Sarah's saying, just the power of affirmations is huge for families, and open-ended question summaries. And I think reflections can be really huge too. And I think some folks worry about, oh gosh, if I reflect, am I going to open a big can of worms and have people talk even more? But sometimes just, I think that's key in helping people really feel heard and really feel understood. So I just had, you know, one or two examples that this is what the patient says, and I want you guys to give me what maybe a reflection might be back to this patient. Not in the data dump mode, not of here's what you should do to fix it, but just reflecting maybe the underlying feeling or the emotion that's going there.
I would start by saying, this is hard for you. I see that this is hard for you. I can understand why it would be hard. That must be a very hard situation to live with.
Yeah, I think so. You know, it sounds like the healthy eating is not as easy as you thought it was going to be, and that's kind of making you feel guilty and frustrated or something like that.
Mm-hmm. Because I mean, I think that way you're looking at the situation and you're validating his concerns and you know, empathizing with the fact that it is a hard situation.
But I think the difference is it's easy to go to like the problem solving mode of, well, here, just put the junk food in a place that's harder to reach, and kind of go into all of the action items that they would need to fix the situation. Where sometimes if you're like Heather was saying, if starting to see you're losing them, sometimes going back to that reflection, I think, can help. And then, how about I put Debbie on the spot for this one? Oh. So, what do you think? My husband and I looked up a lot of websites that show that toxins in vaccines are really bad for babies. Plus, one of my friend's kids got autism after his vaccines.
So I hear your concern that your child might get autism from a vaccine. Yeah, you've done your research and you're worried about, you know, what effect a vaccine might have. And it doesn't mean you have to agree with what they say, but, you know, just I think reflecting back that sentiment sometimes is like, yeah. And you can kind of see if you're on the right track, if people are saying, yeah, like you are really getting it, versus no, that's not what I want to do, or that's not what I'm saying.
Well, the other thing about these two cases, and maybe this is more an affirmation than a reflection, but, you know, I might also point out a positive reflection that, oh, I can tell that you really want to work on eating healthy, or no, you really try to educate yourself about what's best for your baby. And also, yes, you know, some of these other things that you see, kind of combining it with a affirming opening statement.
And there's various different ways to get to the same thing. One of the others is ask, tell, ask, which again is asking for permission to discuss the topic, trying to gather what they may know about the topic, ask if it would be okay to provide additional information, give them that information, and then ask for understanding, kind of summarize what you might have told them about it. So would it be okay if we talked with you about vaccines for a few minutes? What do you already know about those vaccines? You know, I see you've done your research about autism. Would it be okay if I could provide you some additional information? Here's what I know about whether autism causes vaccines or not. I'm sorry, vaccines cause autism or not. And then ask for their understanding and say, does that make sense? I mean, is that something that you would agree with? And so there's various ways that we can use motivational interviewing, and I'm going to go back from the scaling questions to kind of getting to, in the last few minutes, an example, and then walking through the way that I would use all that we've learned in the last 4 or 5 sessions with a specific patient, and how I would use all the various tools that we have to engage with that family. And for me, it starts with the baby book for the first visit, definitely using my Reach Out and Read awesome resources in the clinic, taking a book in with me, maybe using screeners to help define the extent of the problem, using our flyers about community events, flyers about ACEs to offer hope or help for whatever situation you may find the family in. And through all of this, we did motivational interviewing to try and get to what the family wants to do and how we can kind of come meet halfway across the bridge, if you will. And so I'm going back to the example that Dr. Skitsina shared with you a couple of sessions before, where we saw the 2-month-old baby Abby Rose, and Abby's mother was here with her today. We know that Abby's mother was taking Subutex, and Abby spent some few days extra in the hospital, had been growing well, but seems to have fallen off to the 5th percentile today. And on the face of it, you have all this information. Previously, I might have been, oh my gosh, what's going on? Do we know? Is the milk supply good? Is formula okay? But really now I try to gather all my resources together. So for Abby, I would start by getting that read and play book that has all my anticipatory guidance already there in it. I would gather up a reach out and read book from the clinic, maybe even the book about safety, because I might feel that safety is important for this family. I might look at my screening roadmap that Dr. Skitsina talked to us about and think about what screeners might help me understand more about Abby's mom and family. And in looking at the screeners, I would already have my teen care screener that really then points out all of these roadblocks that the family has in being able to achieve optimal care. Mom's postpartum depression screener is a 15. She denies suicidality, but that's a pretty high number for a postpartum screener. So armed with some of this information, and now with our new ACEs screening that we do in the clinic, I realized that Abby's mom's ACEs are a 9. So she has had some significant past problems that may be impacting on how her care or her child's care is right now. And I may have the luxury of our behavioral health folks or our resource team in being able to map out an eco map for me, truly understanding what these resources, what are strengths for the family and what may be limitations for the family. So armed with all of this, I then look for what can I help Abby's mom with? You know, is she breastfeeding? Can we give her some support through the Mommy and Me support group that we have set up? And try to understand where the family's coming from. I also always take in an ACEs flyer to try and discuss, like Dr. Skitsina said, you know, we know that ACEs are something of the past. However, we know the research shows that it can impact the future, it can impact your health and your baby's health. How do you feel those experiences have impacted you? How are you? What place are you so far? And offer them hope with the protective factors and say there are protective factors that can help mitigate what may have happened in the past. Sometimes I will take in a community event calendar. You know, that's not appropriate for a little baby, but a lot of times there's siblings in the family. You know, it may be awesome for the mom to be able to send the 3-year-old, the 4-year-old, the 6-year-old with dad to a community event so that she can get some time with the baby. So I really try to get down to the level of the family, understand what their limitations are, what their barriers may be, and then provide them with whatever support that we have available. And so that's maybe what that secret sauce is, you know, what helps in engaging with these families. For me, it's to make sure that I have an open mind, be non-judgmental about, you know, not approach that mom with, why has this baby not gained weight? What's going on? What have you done to not make this baby gain weight? Engage with their interests, understand what is it that's important to that mom. Try to see what I can do to engage with that. Ask them about their beliefs. Ask them, is this something that is concerning to her? You know, ask them if there's other reasons why that I may not know about. Inquire after their worries and concerns. Ask how they would approach this. Validate their difficulties. I mean, look at her teen care screener. And I found that really you don't have to offer any help. You really don't have to offer any resources at all. it's in just the asking, it seems to be more than enough for a lot of families, and that's sort of, when we first started the Teen Care Screener, we worried that we're going to open a can of worms and they're going to have all these needs and unmet needs, and how on earth are we going to help provide this? A lot of families just tell me, I'm so glad you understand what's going on with me. And that truly then helps us create a shared strategy to meet them halfway across the bridge.
And I think, part of what we've been talking about this whole ECHO series is how to engage families on different health behaviors. And I see it as like a two-part approach. One is, how do you engage families on a systems level and kind of put these different programs in place that help you as a clinic engage? And some of and that takes a lot of work, a lot of times, a lot of meetings, to roll out a new screener, to start an ACEs protocol. Those are all systems level things that provide opportunities to engage. And then today we tried to focus more on just like the personal clinician level, how to use some of those soft skills to engage. But I think many times kind of combining both of those approaches helps a clinic in the overall aspect of things. Any questions that you all had in the last couple minutes, or other thoughts that come to mind? Any final parting words that you wanted to say, Dr. Skidson?
I think it's a good point about the system level versus individual level changes in practices, because I think it's always going to depend on your practice setting. And I think one of the reasons we have lots of meetings in our practice and develop protocols and use a lot of screeners and have all these tools is we have so many providers that see patients in our clinic. And so we're aiming for some consistency. But I think that the skills that you talked about today, I always enjoy watching Dr. Tolliver practice motivational interviewing, because it just reminds me of, why don't I use the ruler more? Because it flows so nicely when you do it, and the scales more. So I think just having the opportunity to think about those individual skills and how to engage with families is really helpful.
And I hope we have met our goal, because one of my goals that I didn't put on there was to engage with you all and have a two-way conversation. So I feel happy that you did engage with us and provide us with that. So thank you very much.
All right, you all have a good week.
Have a good week.